So in this talk, I will talk. I'll be discussing the, the anti-VEGF in retinopathy as a monotherapy versus combination or no. I think those studies has been mentioned by Dr. Ahmed Alvar. In laser compared to cryo for threshold ROP, laser increased the favorable outcome to 80, almost 80% versus 28 in cryo group in zone 1 disease, and reduced the rates of myopia. The early ROP treat high-risk threshold ROP. In 9-month data, it reduced the unfavorable outcome, and it reduced the unfavorable structural outcome as well. Data was same for 6 years follow-up. Plus disease is a significant factor for progression of unfavorable outcome. Advantages of laser therapy for ROP: it is one and done, over 90% success rate. Finite follow-up, long-term effect with 13% risk of retinal detachment from the retinal tears. Laser can be preventive at this situation. Disadvantages of laser therapy for ROP: it's not easy to learn, not completely uncomfortable, need in ICU or OR setting, the need of general anesthesia, cardiopulmonary and the other complication, systemic complication. Multiple anesthesia might be needed, and it carries risks to the babies. Risk persists with type 1 zone 1 ROP. Missed treatable areas in roughly about 5% of laser cases. Posterior disease can ablate a third or 2/3 of the retina. Enter VEGF. VEGF nowadays they are used as a treatment for ROP. But let me tell you one thing. There are concerns because I think we have to finish early. I'll go through those slides. Let me tell you of the disadvantages of anti-VEGF for ROP. It's easy of use, no risks of GA, rapid response, and it is useful in small pupil patients. Also, it carries a better visual field, and you see this is before treatment, and this is after treatment and the completion of the temporal vascularization. Visual acuity, also it carries a less myop than the other modality or laser modality of treatment. But we have concern about the beat ROP. It was not mentioned as randomized control trial, as I mentioned yesterday. So it violated the guidelines. It was assessing the efficacy and of bevacizumab as a monotherapy, and death rate was a little bit high. No evidence of long-term safety, and there was geographical bias on that study. Laser failure was not unusually higher than the previous studies. So we have to have a caution about using anti-VEGF. VEGF is essential for development of the brain, lung, kidney, and we have to be concerned about the dose and the devastating side effect of the drug. And we don't know about the mode of clearance exactly, and it causes contraction of fibrovascular membrane. It needs a multiple injection, peripheral normal looking retina. I agree with that, but I don't know about the functionality of the of that retina, and correlation with the cerebral palsy and hearing loss in the latest review in Canada group. So there are some, the comparison between laser and anti-VEGF. So in conclusion, laser is still effective and safe modality free of retinopathy of prematurity, treated with long-term established results. Using anti-VEGF as a monotherapy carries unknown risks and needs thorough investigations, well-designed significant protocol, monitoring of a long-term ocular, systemic, and developmental outcome. Anti-VEGF as a monotherapy So I want to answer this question. Can I use the anti-VEGF as a monotherapy or combination or no? In the no, I cannot say no, because I cannot ignore the efficacy of anti-VEGF in the decreasing of ROP. Maybe as a monotherapy only, I will use it if laser cannot be given for any reason, media difficulties, small pupil, or inavailability of laser. Combination, yes, I think it's an era of using a combination, but still the laser has an priority. If there is no regression after laser and there is risks of damaging the macula with augmentation of laser, at that stage I can use the the anti-VEGF. But we have to think about what type of anti-VEGF I'm going to use. Theoretically, we have to use anti-VEGF which has smallest size, lowest plasma concentration, and lowest half-life. And I think Lucentis is the choice on those cases. Okay, thank you.